Hey fam, today we're looking at reproductive development and high-yield disorders of sexual differentiation. Let's walk through male reproductive development and the high-yield key players in sexual differentiation. This is one of the most commonly tested concepts on the boards, so let's simplify it. First, the presence of the Y chromosome brings the spotlight on the SRY gene, the sex-determining region. SRY activates the formation of the testes. Within the testes, Sertoli cells secrete anti-Müllerian hormone, or AMH. This hormone causes regression of the Müllerian ducts, which would otherwise develop into female internal structures like the uterus and fallopian tubes. Meanwhile, Leydig cells start producing testosterone, which preserves and develops into Wolffian ducts. These go on to form male internal genitalia, the epididymis, vas deferens, and seminal vesicles. Testosterone also gets converted by 5-alpha reductase into DHT, dihydrotestosterone, which is crucial for forming the external genitalia, like the penis and scrotum. Now let's look at the female reproductive development. What happens in the absence of the Y chromosome? In an XX embryo, there's no SRY gene, so instead of testes forming, the default pathway leads to ovaries. Without Sertoli cells, there is no AMH. This means the Müllerian ducts persist and go on to develop into the uterus, fallopian tubes, and upper vagina. And without Leydig cells, there is also no testosterone, so the Wolffian ducts regress. That's why female internal genitalia are present and male internal structures are absent. Finally, in the absence of DHT, external genitalia develop as female by default, forming the clitoris, labia, and lower vagina. Now let's look at the hormonal feedback loops that regulate reproductive development and function, another high-yield concept for the exams. Everything starts at the hypothalamus, which releases GnRH, gonadotropin-releasing hormone, in a pulsatile fashion. That GnRH travels to the anterior pituitary, stimulating it to release two key hormones, FSH and LH. FSH and LH then act on the gonads. In females, they stimulate estrogen and progesterone production from the ovaries. In males, they stimulate testosterone from the testes. These sex hormones, estrogen, progesterone, and testosterone, exert negative feedback on both the hypothalamus and the pituitary, helping maintain balance and avoid overstimulation. To summarize, GnRH leads to FSH and LH, which leads to estrogen and testosterone, which leads to negative feedback. Disruption at any level, hypothalamus, pituitary, or gonads, can cause reproductive disorders, which we'll explore next. This is Klinefelter Syndrome, one of the most common sex chromosome aneuploidies. It is caused by an extra X chromosome in a male, so instead of the typical 46XY, you have 47XXY. Phenotypically, these individuals are tall males with small firm testes due to testicular atrophy. Because the testes are underfunctioning, there's decreased testosterone. The pituitary tries to compensate, so FSH and LH go up, a classic example of hypergonadotropic hypogonadism. Common clinical findings include infertility, gynecomastia due to the hormone imbalance, and this is a key board clue. As shown on the right, you'll see the karyotype or characteristics body habitus. Make sure to recognize this image if it shows up. Now let's look at Turner syndrome, a classic condition seen in phenotypic females with a missing X chromosome. Instead of the usual 46XX, these patients have 45XO, as shown in the karyotype at the bottom right. There's only one X chromosome. Clinically, they're also often short in stature, and you'll notice the classic webbed neck, which you can see in the image on the top right. This is due to lymphatic dysgenesis. The ovaries are replaced by fibrous streak tissue, leading to primary amenorrhea and infertility. Because the ovaries don't produce estrogen, there's decreased estrogen. And in response, the pituitary pumps out increased FSH, LH. Again, hypergonadotropic hypogonadism. Don't forget the associated anomalies, horseshoe kidney and coarctation of the aorta, both board favorites. To recap, 45XO female, short stature, webbed neck, streaked ovaries, infertility, increased FSH-LH, and congenital anomalies like horseshoe kidney and aortic coarctation is your Turner syndrome. Know this one inside and out. Let's break down complete androgen insensitivity syndrome, a condition where genotype and phenotype don't match. These individuals have an XY genotype, so they're genotypic males, but because their cells can't respond to androgens, they develop as phenotypic females. The root cause is a mutation on the androgen receptor, making the body unable to respond to testosterone or DHT. The key findings are that they have normal breast development due to peripheral aromatization of androgens to estrogen, but they lack a uterus or upper vagina due to AMH secreted by Sertoli cells. Axillary and pubic hair are scant or absent because androgens drive hair growth, and the receptors don't work. Since they're XY, they have testes, but they're usually found undistended in the labia or abdomen. Because the body isn't responding to testosterone, there's no negative feedback. So you'll see increased LH and increased testosterone, and even increased estrogen from peripheral conversion. Management includes gonectomy after puberty to prevent malignancy while allowing full breast development first. PAIS is similar to CAIS, except it's all about the degree of the androgen receptor function. These individuals are also genotypic males, XY, just like in CAIS, but here the androgen receptor is only partially functional. The result? Ambiguous genitalia, which can range from micropenis to clitoromegaly. This is a classic board's buzzword. Because androgen signaling is incomplete, breast development and hair patterns are highly variable depending on the degree of receptor activity. Some may also have hypospadias, where the urethral opening is abnormally placed. Like CAIS, they have increased LH and increased testosterone, but their tissues are only partially responsive to it. Because the phenotype varies, gender assignment is individualized based on anatomy, hormone response, and psychosocial factors. Management may include surgical correction, hormone therapy, and psychosocial support, tailored to the individual. This is Müllerian agenesis, also called MRKH syndrome, short for Mayer-Rudzinski-Kuster-Hauser syndrome. These patients are 46XX females, unlike CAIS, which is 46XY. The most common presenting symptom is primary amenorrhea in an adolescent with normal pubertal development. This is because they have normal ovaries, which means normal estrogen production, so they develop breasts and pubic hair normally. But due to the failure of Müllerian duct development, they're missing the uterus and upper one-third of the vagina. Also, watch for renal abnormalities, especially unilateral renal agenesis. This often shows up in imaging questions. A key distinguishing feature from CAIS: pubic and axillary hair are normal because androgens are working fine. Since the ovaries are present and functional, FSH, LH, and estrogen are all normal. Again, unlike CAIS, which has intra-abdominal testes. This is 5-alpha reductase deficiency, a condition where things change dramatically at puberty. These patients are genotypic males, XY, but due to enzyme deficiency, they're often born with ambiguous or even female-appearing external genitalia. The key issue is low DHT. Testosterone is normal, but without 5-alpha reductase, it can't be converted into DHT, which is essential for external male genital development. However, testosterone is still present, so male internal genitalia, like the epididymis and vas deferens, form normally. At puberty, a surge in testosterone leads to spontaneous virilization. Voice deepens, muscle grow, and phallus enlarges, even if it looked like a clitoris at birth. Unlike AIS, these patients have no breast development because estrogen levels remain low. Hormonally, they have normal testosterone and LH, but low DHT. That's the classic triad. Now let's break down the 3 most commonly tested CAH due to deficiencies in 21-hydroxylase, 11-beta-hydroxylase, and 17-alpha-hydroxylase. All 3 conditions have low cortisol, which removes negative feedback and increases ACTH, leading to adrenal hyperplasia. The most common form is 21-hydroxylase deficiency, where you'll have low aldosterone, which leads to salt wasting, low sodium, low blood pressure, and high potassium. You'll also have increased androgen, which leads to virilization of females, ambiguous genitalia in female infants, and you'll also have the classic lab of increased 17-hydroxyprogesterone. Next column, you have 17-alpha-hydroxylase deficiency, which is less common and has a very different profile. Here you have increased aldosterone, which leads to increased sodium, increased blood pressure, but decreased potassium. And you'll have decreased sex hormone, which means you have XY males that are under-virilized. The classic lab is decreased 17-OHP, but you'll have increased DOC. Finally, you have 11-beta-hydroxylase deficiency. Here you have decreased aldosterone, but you'll have increased 11-DOC, which just acts like aldosterone, leading to increased sodium, decreased potassium, and increased blood pressure. The androgens are also increased, leading to virilized females and ambiguous genitalia in female infants. Labs would show increased 17-OHP and increased 11-DOC. A trick to remember these is to make all the ones point up and all the non-ones point down. What that does is the first number, make that your aldosterone, sodium, and blood pressure, and make the second number your sex hormones and your potassium. So for example, in 21-hydroxylase deficiency, the first number, which corresponds to aldosterone and sodium and blood pressure, it's going to go down because it's a non-number 1. Whereas the 1 in 21-hydroxylase deficiency, the 1 points up, and the second number corresponds to sex hormones and potassium. So the second number will be increased because 1 is pointing up, and the second number corresponds to sex hormones and potassium. I'll create a much shorter video explaining this trick in my shorts section. Now we have 3 questions. Which of the following disruptions would most likely lead to increased LH and increased FSH despite normal GnRH secretion? We have the 5 answer choices: A, anterior pituitary infarct; B, functional hypothalamic amenorrhea; C, Turner; D, Kalman; and E, prolactinoma. The answer is C, Turner, because in Turner syndrome, you have streak ovaries, which leads to decreased estrogen, leading to loss of negative feedback, and thus you'll have increased LH and FSH, despite your normal GnRH secretion. In this next question, we have a 15-year-old phenotypic female with primary amenorrhea is found to have an absent uterus and intra-abdominal testes. Which of the following hormone profiles is most likely? Feel free to pause this video to read the answer choices and select it on your own. The answer is B, which is CAIS, Complete Androgen Insensitivity Syndrome. The key clues here are you have a phenotypic female, that means looking female on the outside, with primary amenorrhea. And the most high-yield clues are the absent uterus and, most importantly, the intra-abdominal testes. That is what makes it specifically CAIS versus any of the other clues that might be the other diseases. Which of the following hormone profiles is most likely? So remember that having this testes produce testosterone will allow it to be aromatized to estrogen. That means you have no receptor feedback, and thus you have increased LH. And thus your answer is B. Finally, we have a 17-year-old female presents with primary amenorrhea. Exam shows normal breast development, normal pubic hair, and absent uterus. What is the most likely diagnosis? Is it A, AIS, B, Müllerian agenesis, C, Turner syndrome, D, hypogonadotropic hypogonadism, or E, transverse vaginal septum? And the answer is B. With normal breasts and pubic hair development, absent uterus, and normal ovaries, you have the 46XX karyotype. And as you can see, this will mean that it's Müllerian agenesis because the uterus is absent. That is it for today, and feel free to like and subscribe.